Thank you for joining us on MD Newsline. It's a pleasure to have you, and thank you so much for just kind of taking the time to come and chat with us. Please introduce yourself to our audience.
Great, thanks for having me. My name is Jaime Almandoz. I'm an associate professor of medicine at UT Southwestern in Dallas, where I'm also a medical director of the Weight Wellness Obesity Medicine program.
Wow. So tell me a little bit about what the weight wellness and obesity medicine program entails.
Sure, we're a multidisciplinary clinic. Involves obesity medicine trained physicians. Some of us are endocrinologists, others are internists or family medicine doctors, and we also work with nurse practitioners, physician assistants, and registered dietitians.
hmm And what type of population do you mostly serve there? Are there specific demographics that are overrepresented, or how do people end up there?
We are a part of an academic medical center where, like with most academic centers, there are challenges with access. So we see people who are at the kind of the more severe end of the obesity spectrum in terms of obesity-related complications. Many of our new internal referrals will be on a wait list for a transplant, but can't be listed because of high BMI, or they may be experiencing significant complications of bariatric surgery.
Mm. So, here at the conference, you've been part of some interesting talks and conversations. Tell me a little bit about those.
One of the sessions I spoke in was about the use of medications for obesity after bariatric surgery. And on one hand, bariatric surgery is a really effective but underutilized tool for treating obesity. If we imagine that 1 in 10 people in the US is now living with a BMI over 40, which was one of the criteria for bariatric surgery, and less than 1% of people who are eligible undergo bariatric surgery. That being said, about a quarter million of people in the US undergo bariatric surgery every year, so there's still a significant proportion of people.
Mm.
What's important to note is even though it's really effective, it's not curative for obesity, which means that all those people who've undergone surgery are at risk for weight recurrence or weight regain.
Mm.
And there are a lot of health benefits to bariatric surgery, and many of them are associated with the magnitude of weight loss, which means that when we experience weight recurrence, we also are at risk for recurrent disease.
Mm. How do people end up kind of on the road to bariatric surgery? Is there a trend towards over recommending or under recommending?
I would say we're in a current situation since the advent of highly effective obesity medications where there is kind of less of a flow towards bariatric surgery. There are lots of reports that bariatric surgery volumes are down significantly in the
Mm.
last 2 years just because people see this as a less appealing alternative to medical therapies.
How does the average person kind of end up on the road to bariatric surgery? What's the process like, and what's the evaluation?
Typically, they'll either be referred into a bariatric surgery center or they can self refer in.
Mm.
Different insurance companies will require different kinds of approvals. Usually, they will require something like 3 visits with the bariatric surgery team and the registered dietitian there. Many programs will require additional testing, including an upper GI endoscopy. Centers of excellence are required to do psychological screening, so patients will often see a psychologist as
Mm.
part of it as well.
What type of medications or treatments have people typically undergone before they become eligible for bariatric surgery?
I- There's a lot of heterogeneity in terms of what people have done prior to
Mm.
bariatric surgery. The vast majority of people will have likely done a multitude of lifestyle interventions, including different low calorie or restrictive dietary patterns and physical activity, too. It all depends on their underlying disease states and coverage in terms of what medications they may have been prescribed or may have access to through their insurance plans.
Mhm. So then, when this conversation about weight gain post surgery, um, what are the factors that make that more likely, and to what degree is that usually present?
So, there are a variety of things that will predispose people to regaining weight after bariatric surgery. When we lose significant amounts of weight, regardless of how we do it, there's a certain thing called metabolic adaptation that our body undergoes, where essentially we require fewer calories than we need for a given workload. So, physical activity will burn fewer calories, like our muscles become more efficient. There will be changes in kind of appetite and satiety, where we will feel hungrier when we shrink our fat cells. They change the kind of the profile of hormones that are released there in a way that can increase appetite and decrease satiety or satisfaction with food. In addition to that, there are a variety of neurohormonal changes in terms of sympathetic nervous system, parasympathetic, thyroid hormone metabolism that can really change our energy balance and a variety of factors. And so What it means is that once we're in a weight reduced state, we're then at risk for regaining weight as one of the body's protective mechanisms from not starving to death.
What are some of the factors that make a bariatric surgery kind of successful? Like, what is the care team doing to either like get ahead of this idea of like a post-surgery weight gain? What are some of the things that they look out for?
It all depends on how we define success, right? And I think it can be really short sighted when we're doing obesity care and saying that the primary outcome is just reduction in body weight and maintenance of reduced body weight. I think we need to look at it in terms of improving health long term and improving quality of life for patients as well. If we're talking about how can we help people to maintain the weight loss that they've achieved through bariatric surgery, there are a variety of things that also happen that can be specific to the surgery beyond the metabolic adaptation that we talked about. So there can be anatomical changes, for example. So if you have a sleeve gastrectomy, that can become dilated or widened so you can accommodate more food, for example. If you have a Roux-en-Y gastric bypass, there may be a dilatation of the anastomosis between the stomach and the small intestine, allowing more food to pass through. And so there are a variety of factors that kind of predispose to that may be related to surgical technique or patient education in terms of the volume of food you may eat at any one time to help to preserve those kind of anatomical things. I think the key part of this is regular follow up to see how patients are doing. The average person who comes to see us in our program for post bariatric weight regain has regained about 40% of the weight they've lost. So if you imagine if someone hypothetically lost 100 pounds with a bariatric surgery, when they come to see us, they've gained back 40 of those pounds.
Interesting. What is maybe the key part of this topic that you think is the most like misunderstood?
I think the key take home is that obesity is a very chronic and complex disease, and that neither surgery nor medications are curative. And given that this is a life course issue, what we need to do is look at what combinations of therapies our patients are going to need over the course of their life in order to have a healthier weight, which will infer then health benefits and then also improvements or optimization in quality of life.
Mhm. What do you think in general? I know that it depends on like the factors associated with the specific patient. Are there any strategies or post-operative care resources, programs, or kind of courses of action that seem to be most effective for people? Um, what practitioners need to be involved? Because part of me thinking that has to be approached from like a multidisciplinary perspective. Depending on what the patient's going through. But what's usually the game plan for a successful, meaning like, somewhat stable resting point for a patient? What's the typical game plan?
Again, unfortunately, a lot of patients in a bariatric care setting are lost to follow up over time. There are care algorithms that suggest appropriate intervals at which patients are meant to be seen back, undergo micronutrient testing to make sure that the micronutrient supplements that they're meant to be taking lifelong are meeting their nutritional needs, bone density assessments to make sure they're not losing excess bone density as part of both the weight loss journey and then also the malnutrition that can occur after bariatric surgery too. So regular follow-up in a center that is accustomed to and trained in looking after patients after bariatric surgery or providing our primary care colleagues with additional education and resources on how to care for people after bariatric surgery, I think is key to this too.
Hmm. What areas of research, maybe emerging or already established, do you think are kind of the most interesting to you, or
Mhm.
that you're that are the most exciting for you?
Sure. I think if we're talking about post bariatric care and weight optimization,
Mm,
I think questions are which agents are most effective for treating weight recurrence or weight regain after bariatric surgery. Research that we've done at our center has shown that GLP-1 or incretin based therapies appear to be more effective as we get new and emerging therapies that work on different receptors and have different mechanisms of action in the body. I think it'll be about looking at, well, which ones have the best health benefits in addition to the weight reduction and not solely look at weight reducing potential. I think the other angle to look at this as well is when do we start medications? Is it appropriate to start a medication for someone living with severe obesity before surgery and start it straight back after? Do we wait until the weight loss trajectory slows or until they plateau? Or if they achieve X% weight recurrence? We really don't have great answers in terms of when to start, but some studies, which are small, would suggest that starting medications before surgery and starting them early before weight recurrence is experienced will likely lead to greater weight reduction.
hmm Does the presence of medication or treatments like that impact things like insurance coverage of the surgery? How,
It If someone, it does not. If medications are covered, they're covered. The risk is that if somebody is treated for obesity before, and if on the day of surgery they fall below the BMI threshold for surgery, then that can impact whether or not
Mm,
they can have surgery.
gotcha. So there's that talk specifically. Are there any aspects of that talk that you think are particularly interesting or stand out that we haven't covered?
The bariatric
Yeah,
talk, that's pretty much it.
gotcha. So what was the second talk or presentation that you were a part of?
Okay. Within the last year, a group of us put together some evidence-informed recommendations for nutrition for patients who are taking obesity medications. There has been a dramatic increase in popularity for using obesity medications just because now we have effective agents that also have benefits beyond weight reduction for cardiometabolic health outcomes as well. I think when you look at studies that model out what happens from a nutrition perspective when people take these medications with the potent appetite suppression that we see with the newer agents such as semaglutide and tirzepatide, intake decreases by about 1,000 calories per day. Unfortunately, the quality of the average person's diet in our country is not really where it should be. It doesn't really align with recommendations for quality. And so if you have somebody who's eating a relatively low quality diet, you then decrease their intake by more than 1,000 calories per day, you increase their risk for malnutrition. And when you look at what's in the news these days about what concerns do people have with these therapies, that includes loss of lean mass, malnutrition, perhaps bone issues as well. So you can imagine if you're creating malnutrition by using these agents, then we may not be optimizing outcomes.
Mm. Yeah, that loss of bone mass is something that I've only heard of kind of in doctor circles. How does that manifest in patients' lives? Like, how are we seeing kind of this potential loss of bone mass like show up in people's lives? Is this kind of more of a long-term thing, or are these things that people typically see sooner rather than later?
Well, many of the people who start and take obesity medications are women in the peri and postmenopausal period, where women are also at the greatest risk for bone density loss
Mm-hmm.
because of reductions in estrogen.
Mm-hmm.
And so we already have a population who may be experiencing loss in bone density. And then if you add on additional medications, that could potentially impact that too. And so I think what we need to do is make sure we have an idea or framework of who at risk individuals could be so that we can do appropriate screening to make sure that we're not getting into an area of concern with regards to bone density for an individual who may have risk factors, and to make sure that we are trying to strive for nutritional quality and adequate, recommended intakes of things like calcium, vitamin D, and regular weight-bearing physical activity.
Mm-hmm. What would you say are the biggest challenges when it comes to working with patients to kind of navigate these potentially negative outcomes
I
also?
don't think there are challenges for working with the patients
Mm,
per se. I think the challenge is many patients aren't aware of the issues that could be there in the
mm,
background, and some of their clinicians may not be either.
mm,
Also, from a bariatric perspective, they may not be seeing a patient, they may not be seeing their bariatric clinician,
mm,
and so they may be in an office where sometimes the doctors aren't even aware that they've had a history of bariatric surgery. Many people are prescribing obesity medications because they're so effective for weight reduction, have additional cardiometabolic benefits. Um, with the changes that people experience in nutrient intake with that, if they're not consuming adequate quality diet, they can be at risk for malnutrition.
mm,
We don't have the same guidelines for nutrition and screening and supplementation for using anti-obesity medications as we do with bariatric surgery, for example. There's much less of the data there than we have with surgery. And so what we need to do is make sure that we're identifying at-risk individuals for malnutrition who could be receiving medications that could cause that. So, for
mm,
example, if we have older adults who are receiving incretin-based therapies for cardiovascular risk reduction, for example, we need to make sure that we assess them for potential nutrient deficiencies, make sure we assess their physical function to make sure things are improving and not declining with treatment, and make sure that at-risk individuals are seen by a registered dietitian and see people regularly for follow-up. These are highly effective agents, and on average, the results are great for people. But what we want to do is make sure that we identify people who could be at risk for misadventure.
mm.
Dietary interventions for people taking these medications can really help to mitigate or offset some of the more common side effects like nausea, potentially abdominal discomfort, in more severe cases, vomiting or constipation, and other issues like that. So I think it's important for us to talk with our patients every time we see them back, to see them back regularly, and to do some troubleshooting if they're experiencing more than would be anticipated symptoms from a GI perspective. I think it's also important to acknowledge that a lot of these are dose dependent as well. And for many clinicians, sometimes the emphasis is more on getting patients to the higher dose to either control their blood sugars or to help the weight come down quickly. Whereas what we need to do is find the right dose for the patient so that they can continue on evidence based therapies that has benefits beyond weight reduction.
What do you normally see that impacts the dosage needed? Are there any kind of other life factors? I mean, we talked a little about women who are in menopause or perimenopause and things like that. And what about with, for instance, like male populations? Or is there kind of like a typical age at which you kind of expect a dosage to be a little different?
Yeah. We don't have really good data with regards to are there special populations in whom
Mm-hmm.
doses or who will be more sensitive to the medication. Intuitively, what we will do is go slower with the dose titration or dose increase titration for people who may be at risk for dehydration or malnutrition. So, for example, if somebody has advanced chronic kidney disease or in older populations, we may start the medication and advance more slowly. I think the important thing to understand is that there's a lot of heterogeneity with regards to what side effects people may experience, which is why it's important to start at the lowest available dose, titrate slowly, see the patient back regularly to work out which dose is right for them.
Perfect. So on average, is there an average age or point in life at which people come into the office searching for bariatric or, being approved for bariatric surgery, or is it really all over the
There's
place?
kids all the way down to, I mean, most surgeons will cut off at about 75.
Wow.
So, I mean, yeah, it's a full lifespan situation.
Wow, fair enough. What is the general, you said most people regain about 40%.
Oh, people we see in our program will have
Gotcha.
gained back 40% of the weight
Mhm.
they've lost.
And then after that regain of the 40% of weight, I'm wondering, is the goal to reduce that further or kind of stay at that 40%?
I think there are a variety of different goals for patients
Yeah.
coming in. For some, it may be, my diabetes has come back since I've regained this weight after bariatric surgery. I
Mm-hmm.
don't want to be back on insulin again. So there may be scale based goals with regards to weight at which they feel most comfortable as you kind
Mm-hmm.
of decrease some of the mechanical pressure of the extra body weight. For others, it may be kind of a cardiometabolic outcome where I don't want to be on 3 blood pressure medicines or I don't want to have to use insulin again. So the goal is really to improve health, and the weight reduction often tracks with that. So what we do is we start appropriate medications based on their health profile and work on getting them close to their goals.
When it comes to surgery, if someone has gained weight after surgery, what is the process, or is there a process for returning back to surgery again? Is that something that you all
Yeah.
face often?
So revisional surgeries are possible, and it all depends on what the mechanism is for the weight regain. There are many patients, for example, who have a history of adjustable gastric banding who've had to have those removed because of device malfunction or because of weight regain, and they may transition to a different surgery, such as a sleeve gastrectomy or Roux-en-Y gastric bypass. Based on those, there can be additional revisions based on the anatomical changes that can be helpful, and those can be traditional surgical interventions with laparoscopic approaches, or there are also endoscopic approaches where they go in through the mouth and can make modifications to the procedure that way.
And then just kind of speaking of these kind of new surgical approaches, are there any new bits of technology or strategies when it comes to surgery that you're particularly excited about or that have emerged recently? Or is it just like the classic, we've already figured out how to do this, and so if it isn't broke, don't fix it type thing?
There are some new surgical approaches which have not been widely adopted yet in the United States and not yet been cleared or approved by most insurance here. They are continuously working on surgical techniques and approaches, both traditional surgery and then endoscopic therapies, to hopefully provide less invasive means to help people to achieve significant weight loss.
Mhm. So, are there any maybe specific surgical revisions or endoscopic procedures that you typically recommend for patients with significant reoccurrence, or how do you decide which of those are appropriate?
That's highly individualized, and I
Mm,
think it depends on a variety of different reasons, and it depends on a variety of different factors,
mm,
including what surgery they've had,
mm,
what kind of challenges they've experienced from both a weight or other disease recurrence perspective.
mm. What are some of the challenges when it comes to in maintaining interdisciplinary care for patients? Whether it's gaps in records or just gaps in communication, where are you finding most of the spaces where patients kind of could use improved care, communication, and things along those lines?
I think the challenges most patients who undergo bariatric surgery get lost to care, if you will,
Mm,
from their surgeon's office or from their bariatric provider, and making sure that we incorporate pathways within primary care where they'll be seeking kind of their regular health care and health maintenance to make sure that clinicians in those areas have appropriate resources for screening for post bariatric deficiencies, for helping to address potential post bariatric complications like dumping syndrome, and to make sure that clinicians are aware about bone density screening and other factors that should be done. Obesity is a very chronic and complex disease, and there's a variety of different responses that we're going to see to any intervention,
mm,
be it a diet, be it bariatric surgery or
mm,
anti-obesity medications. And I think it's so important for us to educate our colleagues and our peers with regards to the variety of responses that can be seen,
mm,
so that when patients come in and they don't have the average or expected change in body weight, that
mm,
we're able to talk through this with the patients without having stigmatizing reactions to their lack of weight loss. I think it's so important as we acknowledge a challenging disease like obesity to make sure that we meet patients where they're at and we provide them with care that would be analogous to any kind of disease state. If somebody comes in, for example, with high blood pressure and we start a medication and their blood pressure is not within goal, we don't give them a hard time about the medicine not working, right? We add another therapy, we find something else that works. But when it comes to obesity, unfortunately, there can be a lot of stigmatizing experiences that patients have where clinicians may expect everybody who starts on a treatment to
mm,
have a similar response to what they see. And so I think it's important for us to have these conversations with peers so that we all understand the challenges of treating obesity and how to approach this in an evidence based way, but also that we can have constructive conversations with our patients.
mm. How does mental health come into play with all of this? Because we've talked about the stigma of obesity often not being seen as a chronic illness, even in healthcare fields. And, when we think about people's relationship with food, there is often sometimes an emotional aspect to it. So when it comes to quote unquote success post surgery or, quote unquote success post, medication, how are we kind of discussing patient mindset, emotional state, and things like that? Are those conversations that are even being had?
They're conversations that should be
Mm,
had, and unfortunately, I think many clinical settings in which obesity is being treated or in which patients are accessing obesity medications, there's neither the time nor the resources for this to be done in an effective or iterative way. And to kind of cut to the chase, I think things that are important to make sure that we are screening for mental health challenges in our patients. I think all of us are living in a state of stress and sleep deprivation in a way that impacts our mental health and our overall health. And so making sure that we provide appropriate support, coaching, and interventions to our patients who are on any kind of health journey or even as a matter of primary care. Mental health professionals can be incredibly helpful for helping patients to identify what it is that they want to work on from a health and weight perspective, what their why is, to put in place, if you will, kind of using the SMART goals kind of framework to set actionable items that they can work on so that we can see progress, maintain engagement, and if not, troubleshoot with the patient and be supportive.
mm. How do you balance the use of a medication with the use of surgery or revision surgery? Like, how do you kind of decide where to draw that line?
I think this is something that you need to have an engaged conversation with patients about, respect their autonomy and their and what their desire is with regards to treating their underlying disease. Because again, this is going to be a lifelong journey for treating obesity. And so I often tell patients that I live in a world of and not ors. And so we can consider both treatments and we talk in a balanced way about what the risks and benefits are to both. I'm seeing a trend recently with regards to patients significantly preferring anti-obesity medication therapies just because they are so much more effective than they had been previously. And I think it's important to discuss with patients that, you know, not everybody sees the response that they want from these treatments. And that if you don't see the treatment response that you want, why don't we talk about something else that may be helpful for you? And that may be another medication therapy, it may be a bariatric procedure, or another lifestyle intervention.
Mhm. That sounds great. Let's see. Are there any key takeaways that you would like your fellow physicians to kind of take from these three presentations and conversations that you have that you feel like is mostly absent in the landscape of the conversation that's being had already?
Sure. I'd like to reiterate that obesity is a chronic and complex disease, and that neither medications nor surgery is going to be curative. So, what we need to do is work out what kind of combinations of therapies and integrations and sequences will our individual patient need throughout their life course in order to decrease their body weight and improve their health. Because the goal of obesity care is really improvement in health and quality of life, not just decreasing the number on the scale.
Mm.
It's important not to conflate access to drug or surgery with quality obesity care either. We need to incorporate lifestyle factors such as optimizing nutrition patterns, facilitating physical activity as much as that patient is able to do, and also incorporating the mental health perspective as well.
When it comes to research and gathering and preserving of data, whether it's through clinical trials or through health records, so that we can maybe potentially gain insights on things, what do you hope to see in the future as far as that goes? Where are the areas that you hope to see improved in?
With new and emerging therapies for obesity care, we're now at a stage where we're not just focusing in on which medication or intervention can bring the greatest weight reduction. We're seeing therapies that work in different ways on different receptors. So, what we want to do is work out which therapy is best for that patient in the room. So, a more precision approach to obesity care across the diversity of patients we serve.
Thanks for joining us on MD Newsline. This has been an amazing conversation.